How's it going, guys? We have a past level question for pathology HIV step 1 for internal medicine 2CK. Before we get started, please subscribe to my channel. Really appreciate it. Give you a like, really appreciate it. Find me on Instagram, Mehlman_medical, MEHLMN_medical. Links down below. Find me on Telegram. Links to the Telegram group channel down below. Now start the clip. So 25-year-old woman, she has HIV and she's had personality change over the past 2 weeks. She's had 2 episodes of pneumocystis pneumonia during the past year. MRI of the brain shows multiple brain-enhancing lesions, frontal parietal lobes. Question wants to know which the following is the most likely explanation for the findings. So let's just hop to the answer choice here. Choice A, central nervous system demyelination, wrong fucking answer. That would refer to multiple sclerosis. Okay, woman 20s to 30s who lives far from the equator and is going to have neurologic abnormalities, miscellaneous UMN findings like Babinski, clonus, can be urge incontinence. It's a long discussion. Some students say overflow incontinence. It's fucking wrong. It's urge incontinence. I've seen it all over the NBME exams. Eye findings, okay, optic neuritis, Marcus gun pupil, internuclear ophthalmoplegia, medial longitudinal fasciculus syndrome. Wrong fucking answer. Choice B. Actually, real quick, you should just know oligodendrocyte is the cell that's fucked up in multiple sclerosis. Okay, it's a T cell attack against myelin basic protein. That's an answer on the NBME. Just against myelin sheaths, okay, but in the CNS oligodendrocytes, you treat acute flares with IV methylprednisolone steroids, okay, and you give interferon beta between flares to decrease recurrence. You give baclofen, which is a GABA B receptor agonist to decrease spasticity in multiple sclerosis. As I already said, wrong fucking answer. Choice B, central nervous system infection, correct answer. I said it's pass level. Some students think this is like too easy. It's a catch of some kind. It's not. This is toxo. We have multiple ring enhancing lesions here. That's how you know primary CNS lymphoma is wrong. So it's high yield that you know that in AIDS patients, especially if the CD4 count drops below 50, I didn't mention it here, but you need to know primary CNS lymphoma is exceedingly high yield, but that would be a singular lesion. Okay, and it can be described as ring enhancing. Ring enhancing can mean toxo, can mean abscess, can mean metastases, cancer. Okay, so many things. But we have multiple lesions here. Now, metastases is fucking wrong. It's not that it's outrageous. I mean, if we had a 50-year-old woman, 60-year-old woman, you say, well, couldn't it be? And she doesn't have HIV. You could think about things like breast cancer mets, right? Or lung mets and a smoker. So it's not outrageous, but there's obviously going to be a better answer. So the key here is the fact that I said that this patient has had 2 episodes of pneumocystis pneumonia the past year, which implies that she is not on TMP-SMX prophylaxis. So TMP-SMX is both the prophylaxis and treatment for toxo once you fall below a CD4 count of 200, but it's also the prophylaxis for toxo, holy shit, which normally comes in at a CD4 count of 100. Treatment for toxo is sulfadiazine and pyrimethamine. It's different. They asked that on 1,2-CK form. Okay, they have TMP-SMX. Wrong answer. It's sulfadiazine and pyrimethamine for the treatment. But this is the USMLE's way of telling you the patient's not on prophylactic TMP-SMX. You could say, well, if they had 2 episodes of the PJP, pneumocystis pneumonia, and they were presumably given TMP-SMX for treatment, okay, but they're not on it prophylactically, clearly. So that's how toxo is the answer here. You say they're not on the prophylaxis for toxo. So we already said primary CNS lymphoma is fucking wrong because this would be a singular lesion. Then multiple infarcts, I mean, this is fucking wrong because these wouldn't present as ring-enhancing lesions. The patient would have hypertension. Patient's going to be older. It's going to be hypertension, okay? I've had students see this question on the NBME exam and think that they're talking about PIC disease, frontotemporal dementia. It makes no fucking sense, okay? You'd have an older patient. That's idiopathic frontotemporal dementia. So personality change, apathy, disinhibition, nothing related to HIV. AIDS complex dementia can present with personality change, wet, wobbly, wacky. Okay, sounds like normal pressure hydrocephalus in an HIV patient. That's AIDS complex dementia, okay? Multiple infarcts, wrong fucking answer. You know the deal. To make more content, if you like my stuff, subscribe my channel. Appreciate your time. That's it.